All right. Okay. So I think we're now streaming live, and um, I just wanted to just hold on, and let me make sure if you have the YouTube link, I think that should also be starting to broadcast at this moment. So I'll just start by introducing myself. Dr. Chireka has also joined us. All right. So I'll just start by introducing myself. So I'm Emmanuel Magara. I guess I can also say Dr. Magara now. But I also grew up in Zimbabwe and then came to the US almost close to a decade ago. And I've always been interested in the issues of Zimbabwe and the healthcare system. And one of the things that I've always been passionate about is to see how best we can network and get together and know who's doing what so that we can able to collaborate and do things that are meaningful all as one goal. So when I was trying to come up with a panel, I just tried to find out as many people who are doing amazing things, which you guys have been doing, and I'm really glad that you could all make it. So we'll just start by doing some introductions. So for those who are joining us, we have Dr. Chireka, Mr. Zikiti, Dr. Rabao, Dr. Kaseke, Dr. Changamire, and Dr. Mkono Shuro. So I'll start with Dr. Mkono Shuro. Can you just tell us a little bit more about yourself?
Okay. Thank you. My name is Dr. Sydney Mkono Shuro.
Yeah.
With vested interest in healthcare business, in particular healthcare funding, trying to come up with sustainable healthcare funding solutions, because that really is the problem for health, and how to keep people out of the necessity for paying, for needing to pay out of pocket for healthcare. And of course, given the fact that our healthcare is extremely expensive, in fact, we're the most expensive in the region, for one reason or the other. I've developed an interest in that and say, how do we lower that cost?
Okay, oh, great. Yeah, we'll definitely be hearing more about that. And then Mr. Dr. Changamire.
Hi, everyone. My name is Tej Changamire. I'm right here based in South Carolina. I'm a family physician by training, and actually trained at the University of Zimbabwe a decade ago before I moved to the US for further training. And I've been involved in healthcare in Zimbabwe for quite a long time now, since like the mid-90s when I was a medical student there. And done some work in public health in Zimbabwe and clinical medicine. I've consulted with a few organizations. And just like Dr. Kodoshiro was saying, most recently, actually, my interest sort of like shifted a little more into trying to figure out how we can use the private sector to complement what the government and the public system is doing to improve healthcare quality and access in Zimbabwe. So I just most recently got a business degree, and now I'm trying to figure out how we can work at the intersection of both public health sector, business, and clinical medicine to improve the quality of care and the access to care for all the folks back home.
Oh, great. Thank you, Tej. Dr. Kaseke.
Hi, everyone. So my name is Monashe. I am based out of San Francisco. I have been in the US for about a decade now as well. I'm also the founder of an organization called Impact Pharmacy that is based out of Zimbabwe, out of Harare. And the main focus of that, or I guess where my greatest passions are with Impact Pharmacy, is just getting a wider selection of medications available in Zimbabwe, getting more medications registered, and then making payment options a lot more accessible for people both in the diaspora who are supporting their relatives at home, and then also providing other convenient services such as delivery for the patients who are in Zimbabwe.
Great. Thank you. Dr. Nyagabao?
Right, hi everybody. My name is Marlon Ralph Nyakabao, and just in case if anybody's wondering, there's no relation to the Nyakabaos that are famous. I am my own Nyakabao. I get that question a lot, even from the first day I was registering in medical school up to the final exam. People kept on asking me, even up to today. So just to get that out of the way, that I am my own Nyakabao, and in that way, I'm a young medical doctor who's really passionate about bringing technology and into the healthcare sector, using technology to solve some of our perennial healthcare related problems. So I am currently working as a general medical practitioner based at Chinhoyi Provincial Hospital. But I'm also now an e-health consultant for about 2 years now. So what I do is I work with startups and companies that are trying to launch various kinds of e-health services and products. And then I kind of just help them on how to get that done. So that's kind of like a fun thing that seems to be growing on and on. So I'm happy to meet all of you. And for those wondering, I'm actually based in Zimbabwe. I've been based here since birth. So this is where I've been born, bred, and buttered, and jammed, and toasted, and yeah.
Great. Thank you. Mr. Zikiti.
Hello, everyone. Yes, like Emmanuel said, my name is Chris Zikiti. I'm based in the UK. I've been in the UK for the past 17 years. I work for the National Health Service as a strategic program manager. I trained as a nurse initially, so my background has been mental health nursing. I'm quite passionate about mental health nursing. I'm also the secretary for ZHTS, which is the Zimbabwe Health Training Support, which is a diaspora organization in the UK. I spent some time in Zimbabwe doing some networking, doing some needs assessment. I've spent some time with people from the UZ, people from other hospitals in Zimbabwe, trying to understand exactly the needs in Zimbabwe. I've just returned from Zimbabwe about 3 weeks ago, so I'll talk more about it. But yeah, I'm quite passionate about how best we can support, especially the vulnerable people, children and young people in Zimbabwe. That's my main passion, and also how we can improve training in Zimbabwe for healthcare professionals.
Great. Thank you. So Ms. Dr. Chireka.
Hello, everyone. Sorry, my voice, I've got a sore throat, but should be able to talk. I could not miss this occasion. Anyway, yes, I'm also a trustee of the HTS. I work with Chris Zikiti in that.
Yeah, man.
Yes. So, yeah, I'm a GP in Kent, Folkestone, and I'm into, I would call myself a patient advocate, because I want to make sure that the patient is involved in any decision making that we do. Because when people talk about health systems, when people talk about how to change the systems, there's only one person who is missing, that is the patient. So I want to make sure that the patient is at the center of whatever we do. That is why I've decided to demystify medicine and try and explain medical conditions in a lay term, in a way that many in the street can understand it. That's why I wrote my blog, which I try to write a few articles and raise awareness, and also try to take advantage of the social media to make sure that people are engaged. And I'm finding out that people are really getting engaged slowly, because at first it was just people complaining about how bad things are, but it seems the debate is changing. Thank you.
Great, thank you so much. So thank you so much to our panelists, and I just wanted to let our audience know that we will also be taking questions. If you just go, there's a link where you can just click on the Google Hangout page, and then you can just type in your questions as we go on. So For our panelists, I guess at this point, I know a little bit more about certain things, and I just want you guys to help share with the world some of the amazing things that you're doing. For instance, Dr. Mkono Shuro, you've been involved with trying to advocate for affordable access of healthcare in Zimbabwe. What are some of the challenges that you've been facing, and as a local doctor, in trying to make sure that people have access to good healthcare?
Yeah, so the main challenge really is payment for services. That really is the main challenge. You've got enough manpower, you've got enough in terms of infrastructure capacity.
Mm-hmm.
There's lots of work that has been done on a national scale as concerned. There's a clinic, at least there's a clinic within 10 kilometers of every household anywhere in this country. But it's the funding element of it. We've had problems, like, you know, probably any other country, I guess, with your medical insurance companies struggling to then pay for doctor services. And that's a really big problem, because then when the doctor cannot meet his day-to-day expenses, the doctor cannot meet his own living expenses, then that has then created or pushed doctors to the place where they've had to then force, you know, a fully paid up member to then pay cash to the doctor and then claim, you know, with his own or her own medical aid. And that really creates a problem for everyone. That really, like I said, is the biggest problem. And that is where, you know, the solution has to be found.
Thank you. Dr. Changamire, I know you've been interested in the whole healthcare finance, including your background. What are also some of the things that you've been noticing when it comes to Zimbabwe healthcare financing?
Right. Well, I absolutely agree with what Dr. Mkono Shuro is saying, that you know, healthcare financing is a challenge, and it's, you know, you see that it's not only a challenge in Zimbabwe, even in the U.S. You know, it is a challenge to get everyone to have access to financing mechanisms that allow people to access health services. You know, now if I would wear sort of like my non-doctor, maybe more of a business hand, I would say everything is sort of like interlinked. So if we have, I guess, you know, a population that is be low income, with no companies that cannot afford to pay for people, that becomes, you know, very, very, very challenging. So some of the solutions that have worked really well in some of the, I guess, up-and-coming emerging markets have to do with, you know, the rise of, I guess, the economies in those countries. So I look, for example, at countries like, you know, Mexico or Brazil. In some ways, countries like India, where the middle class has been growing, and then companies are at least afford to pay for healthcare services for the population, then that allows insurance companies to be sustainable, that allows insurance companies to be profitable. And if insurance companies are sustainable and profitable, then their obligations to pay doctors. So I think what's happening right now in Zimbabwe, back home, is sort of like a consequence of some of the economic challenges that we are seeing back home. And my hope is those get better, then the whole financing mechanisms for healthcare systems will get better as well.
Oh, great. Dr. Nyagabao? I don't know if it's...
Yes.
Yeah, so you're also involved in technology, and you're also practicing in Zimbabwe. Do you have any comments, as in, is there any role for technology in all this, and healthcare financing, and trying to make more healthcare more accessible to people?
Well, definitely where we find ourselves in the 21st century, I mean, particularly Zimbabwe, is not the best of places. We have gone off on the worst of starts. We are in the middle of a crisis that very few other countries have had to go through. So we are facing new problems, but the good thing also is there are new opportunities out there, and what that is there's technology, advances in information and communication technologies that are going to enable us to somewhat leapfrog over all these problems. So Dr. Mkonosho talked about the issue of access. I think it was last year, it was 2014, the Minister of Health came to Chinoy for one of the official ceremonies. And he said in 1980, the target was for there to be a clinic within 10 kilometers of everyone, that no Zimbabwean had to walk more than 10 kilometers to get to a health facility. But he had to admit that in 2014, that is still the goal, that there are still some places where people have to go through such challenges. That even though they've tried, that still is the mission. So with technology now, and particularly what we are seeing with things like telemedicine, we are using advances in information communication technology to overcome that distance barrier, to bring healthcare closer to people. And hence we are seeing a telemedicine pilot that's being currently held in Nyanga province, where centers are being connected to a district hospital, such that the doctor who is at a district hospital can be able to attend to patients out there in the peripheries. So these are the opportunities that are there. As far as financing, well, there's definitely a role for it, that technology can make healthcare more efficient. And by making it more efficient, it means you can get to make it less costly. Just one good example is with the issues of medical aid, that the medical aid societies, that these insurance companies, some of them are failing to make a profit or are really crying that there is it over-servicing or something like that, that, you know, the patients are going too many times to see the doctors, and then that ends up just costing them so much. I think it was First Mutual that said 90%, they have like a return for 90%, that 90% of the claims end up most people are just using the health service so much. So with technology, there's a way of monitoring that. And one thing that the medical aid societies are trying to do is introduce point of care devices that will enable them to kind of track to see if this client has abused the system so much, or just to go past some of the corruption that we've been seeing in the sector, where, you know, false claims, where someone will bring a relative and then the relative ends up using that person's medical aid and so forth. But with introduction of something like a biometric sensor, you can get to really see if it is the actual patient that was got to be treated. So technology has the ability to improve access as well as improve efficiency, thereby reducing cost and making things easier.
Oh, great, thank you. I know, Dr. Kaseke, you're also involved in using technology in your pharmacy, Impact Pharmacy. Any comments that you've gotten to learn, especially given what you do here in the US as a pharmacist and trying to facilitate e-commerce and work in pharmacy using technology in Zimbabwe?
So I'm going to highlight just two things that we have done differently that not a lot of other pharmacies are doing. So the first thing that we did was we've set up an online payment platform. So, Dr. Mkono was correct that there are a lot of patients who get their medications prescribed, they get to see their doctor, and either certain medical aids are not able to, they haven't been able to keep their promises to make those payments, and that has forced us, with a few of them, so not a lot, but we have a few that we've said, well, until their payment model gets a little bit better, we can't necessarily accept those medical aids. So what we have done is we set up an online payment system that allows those with relatives in the diaspora to be able to pay to help them pay for that medication if they so choose, from the convenience of their phone or their laptop. So if somebody came in and they had medications that cost $25, for example, usually for most people in the diaspora, when you're sending money back home, the fees alone are $20 to send it. So that ends up forcing you, if you're in the diaspora, to send a little bit of a larger amount each time for those healthcare costs. So our online payment system will enable you to pay just the $20 that is required for their medication and it's paid directly to Impact Pharmacy. The money doesn't have to go through MoneyGram or Western Union, and the patient goes to pick it up, and then after they pick it up, they bring it to us. We just send you an online invoice. You pay from here, and then we send a text message to the patient, or we just go deliver to the patient's home. So that's that's one thing that we've done. And then the second thing was we've incorporated systems that Zimbabweans use a lot. So WhatsApp, for example, everybody is on WhatsApp in Zimbabwe. It's probably one of the most used platforms. So what we've done is we have an Impact Pharmacy WhatsApp line, and our patients know that they can ask us questions on certain things. So basic ailments that don't necessarily need a physician, but that need over-the-counter treatments. So allergies, itchy eyes, those kinds of things. Patients sometimes can text us and let us know, hey, this is how I'm feeling, give us a list of what their symptoms are. Our pharmacist can pick what the correct medication is, and then we can take it to them. So they never have to leave their home. They just text us. We come up with what the best thing is. We deliver the medication to them. They give us cash when we get there, and we come back. So yeah, those are some of the things we've done.
Oh, great. That's really amazing. So I guess I also have to move to and ask Dr. Chireka. So you've been trying to advocate with Mr. Dzikiti programs in Zimbabwe that help rebuild the infrastructure in terms of human resources in healthcare. What are some of the things that you've been noticing, and do they relate in any way to these issues of healthcare financing? What are some of the things that you have actually gotten to see is going on the ground?
Yeah, one thing which we have noticed is that if a person in Zimbabwe wants to have access to reliable medical information, we don't have an online reliable database for medical information. In the UK, we've got so many platforms that we can refer patients to. But in Zimbabwe, we don't have that. And one of the things that we have noticed is that design of services, even design of any system or pathways in Zimbabwe does not involve patients. Patients are not involved in this decision making. But my argument has always been that no decision about a patient without the patient. We may talk about fraud, we may talk about abuse or inappropriate use of medical services. As long as we don't educate the users, as long as we don't involve them, we will be crying and crying and crying. But I think what we now need to do is to engage with our public to talk about self-management. But we are now finding that in as much we still have infections affecting things like malaria, TB, and HIV, but we are noticing now that non-communicable diseases are becoming more and more common. Young people are getting stroke, heart attacks, diabetes, and blood pressure. So these are some of the things that we always tell patients that, okay, you are what you eat and you are what you do after eating. So I think health education, prevention needs to be implemented. And what I'm seeing in Zimbabwe, we are focusing on sick care and not focusing on health care. And if you talk to funders, they are not keen on health prevention. They are only keen on trying to treat people. So that's where the problem is. Mm-hmm. We have got limited resources all over the world. We need to make sure that we are using them wisely. Thank you.
Thank you. Dr. Nyagabao, I'll come back to you. So have there been any ways in which you've been seeing the trend towards patient, or Dr. Konoshiro, either of you, patient access to medical information in Zimbabwe? What are some of the platforms that you've noticed that seem to work best? And are there any ways in which people like Dr. Chireka, who are interested in patient education and patients empowerment, being able to actually have channels in Zimbabwe that are effective?
Sid, do you want to go first?
No, you're the technology expert.
All right. I think it's two things. First is patients having access to their own medical records, I believe. Then the other thing is just having access to general health information. Yes. All right. So maybe I'll start on the second one. what we are seeing, I mean, with as far as the public just getting health information, traditionally, you know, people have had to find information from wherever they can. So people would ask neighbors, would ask grandmothers, okay, this baby has diarrhea, what should we do? And some of the times that advice is good. Most of the time, it's not so good. But advances that we are seeing now, we are having guys on TV like Dr. Sid there with his regular program, you know, just trying to simplify things for people. There are radio programs every now and again. We're also getting technology-wise in the M-Health sector. I think it's one of the mobile network operators. There's a subscription service where people can subscribe to get information on diabetes, on how to lose weight, on women health issues and stuff like that. So just making access to information a bit broader. Yeah. Then as far as patients having access to their own medical records, moving away from paper, you know, we see a lot of patients having to carry around an actual book, you know, their booklet that has all their history, the drugs that they've been taking and all their visits and so forth. What we now need to maybe move towards is the patient health record, which is like an electronic system that can then be accessed universally. That if someone is being seen by another doctor in a different locality, their information is readily available. That is still something which we are a bit far from. Firstly, because regulation is not yet there. Second, I know a couple of local entrepreneurs that are developing their own electronic health record systems. I know one guys I was quite impressed. They worked out their system with a personal health record inside it to just incorporate it in the whole package. But the others, yeah, so we are still, as far as the personal health record is concerned, we are still far away, and people are having to rely on paper, on having to carry their books with them.
I'm going to jump in for a little bit and talk about how we've used this as an opportunity for us to grow our business as a pharmacy. So the difference with when you go to see a pharmacist and when you go to see a physician is that you can consult with a pharmacist for no cost, right? So whether you walk in or or on a different platform, historically, when you go in to see a pharmacist, they give you a recommendation without, or they might refer you somewhere else. But if it's something that can be treated with over-the-counter medications, they do give you whatever information you need at no cost. So we have further used this again on WhatsApp. So everybody knows that if they have a question, instead of, they have our phone number saved. So we encourage people, save our phone number, give it to your friends, your relatives. That way, when that one time comes up where you have a question, you have a WhatsApp phone number and you have a pharmacist on the other side, and they can at least either refer you to the right place or be able to give you accurate information as far as how to best use that. So that has been, I guess, a business advantage for us, just recognizing that, you know, we're not, unlike physicians, we don't get paid for a basic consultation anyway. So we've used that as a, I guess, like a public health initiative to make sure that patients are more aware of, you know, what the best preventative measures are or best treatment measures are. But then at the same time, we've also used it for the advantage of the business, because then a lot of people have our phone number. A lot of people are more likely to come to us and then share our information with some of whoever's in their network.
Great.
Yeah, could I come in? Sorry, could I come in on that?
Yes.
Can I just jump in quickly as well?
Okay, can we have
okay.
Dr. Konoshiro, then Dr. Chireka?
Yeah, I also wanted to jump in as well.
Okay, Dr. Konoshiro, Dr. Chireka, and then Dr. Nyakabao.
Okay. Okay, just look, I just wanted to follow up on what Dr. Chireka talked about. I think we didn't quite zoom in on healthcare versus, you know, what we're doing, which is basically just, you know, sick care or curative care. You know, a society that considers an obese man, where obesity is a sign of success, shows you there's something wrong with the psychology of that society. The reason why the system is failing is because it's mainly curative. The reason people are now consulting with pharmacists, which is something they really shouldn't be doing, because we've actually come across a couple of disaster cases, because the pharmacist doesn't actually get to examine the patient. And sometimes we're actually creating bigger problems. Of course, a lot of times pharmacists are helping, but because patients can't even afford to see the GP, if they can't see the pharmacist, now they go to the prophets. So we need to find a way of making sure that a GP is accessible to everyone, commoditize it if it were, and allow the GP to be able to earn a decent living without having to fleece the patient or the medical aid. So there's a rethink, and I think it's along the lines that Dr. Chireka is talking about. If we can teach our people about wellness, then they visit the doctor only when they need to visit the doctor. And then we remove the burden off the financing system.
Okay, thank you. Dr. Kaseka, I'll leave you to comment at the end. Dr. Chireka.
Yeah, definitely. I'll just summarize, but thank you, Dr. Mkonoshuro, for just putting it clearly to everyone. I wanted to take on the issue of pharmacists helping out. There is room for pharmacists to help out, but if pharmacists are helping out in a situation which is not monitored, then that's when we have got these disasters. In the UK, we have got teams called medicine management teams, which do medication reviews, and the team involves pharmacists. Also, GPs do that. So when someone goes to a pharmacy, they can have their medication reviewed. And we know in the UK, a lot of people are on medication which they are not taking. A lot of people don't know how to take the medication. A lot of people are having side effects. So at the end of the day, we may be thinking we are treating blood pressure, we are treating diabetes, we are treating heart attacks. We are not, actually, these people are not benefiting. At the end of the day, the funders will keep on crying and they're running out of funds. We're not affected. They should be engaging with the pharmacists, engaging with the GPs to make sure that the resources that they are using on these drugs can be channeled back to allow access to the doctors, allow access to the pharmacists in a more organized way. So there's in my local area, we have managed to save 20 million from just meds management. So I know a lot of can be done in Zimbabwe to make sure that we review medication, we manage it properly, and the resources are channeled back to the GP. Sometimes money does not follow the patient. When the medical service save that money, they'll buy mansions, they'll buy cars, expensive cars, they'll pay themselves bonuses. But what we now need new ways of thinking. If we save money from drugs, we are using generic, or we save money because we are managing drugs well, then that money should be channeled back to the pharmacist, should be channeled back to the GP, and allow access to healthcare. Thank you.
Thank you, Dr. Chireka. Dr. Nyagabao.
Oh yes. I just wanted to comment there on the pharmacies consulting. I mean, being in technology, I'm a big believer in making things more convenient. I think that's the main thing and why I'm doing this. Say, let's make healthcare or even practicing medicine more convenient through technology. So I appreciate the advantage of that. But where we are right now, this is really becoming a major problem. I've had to even write a letter to my provincial medical director saying we need to do something about this. Yes, I think that the business sense of things is what's really taking over. It's no longer the patient, in mind, but the business. Because the economic environment is so tough, people are just trying to survive and remain afloat and make sure that businesses are as viable as possible. So we're then getting a very much abuse of the system. So I have many cases that I can count as a patient who fell off a bicycle, went to the pharmacist. The pharmacist gave them a week's course of prednisolone for just falling off a bicycle. The girl walked into my rooms 2 days ago. We went to the pharmacy said she had an itch down there, a general itch, something that could be candida. She was given a hydrocortisone cream and a week's course of prednisolone. Someone with diarrhea ends up on all sorts of things. So there's really an abuse that's really happening. there. And I think it's the poor regulation, and also, I wonder how Impact is kind of doing this, how they've managed to overlook some of the regulations, some of the regulations involved as far as maybe health advertising, as well as this, teleconsultation. Because one thing that I've found out in Zimbabwe is there are so many rules on doctors, but none on prophets and herbalists, and everyone else seems to do whatever they want. But a doctor, no, you can't.
All right. So here's the thing. So it's really unfortunate that they've been, all these cases that are this way. But the first thing I want to say is we're not in competition, right? So like when I'm talking to my pharmacist and when I'm talking to my teams, it's not like, oh, hey, come to us instead of coming to the doctor. Absolutely not. So that's why I kept going back to over-the-counter medications. I say that every single time, like OTC medications. And I think the advantage that this has, we have a lot of physicians that are within our perimeter, and our pharmacists know that, hey, like these physicians are going to be the best person to help give diagnosis on certain things. So when patients come in, you absolutely want to send them over, because our goal, it is absolutely for the greater good of public health as a whole, right? So what we're trying to avoid is having them go to the prophet or having them go to the herbalist. So like if it's an over-the-counter thing, absolutely, we will help them out with that. But then our pharmacists know, hey, this is where you draw the line. We have so many physicians that we work in partnership with, and we actually end up being the ones that send them the majority of their patients. So it's sad that there's been this abusive system, and there definitely needs to be something that is done for that. But when I look at it, it's not like pharmacy versus, or it's not like you're choosing, do I go to the pharmacy or do I go to the physician? We're a partnership, and what we're hoping to do is be those public health advocates that say, hey, with this kind of thing, you need to go see the doctor down the street. And then once they give you that diagnosis and they give you something else, because even with that, there's so many medications that if they came in, we can't dispense them without the doctor's prescription, right? So we can't just give them something if it's a prescription thing. The doctor needs to have seen them for that. So we have very clear guidelines, at least with Impact, as far as how this is going to work. And we look at it as a partnership. We look at it as, hey, we are helping the physicians. We're the ones that are channeling patients to the physicians and saying, hey, for something like this is not something you come to us to see. You need to go to the doctor down the street. And then after they've done that, you can come back to us with something else.
Okay. Dr. Mkono Shuro. Okay, we'll go. Dr. Mrs. Zikiti, yes. You can go.
Yes. Oh, yes, Aida.
Yeah, Mrs. Zikiti, then Dr. Mkono Shuro will come to you.
Okay. Thanks, Emmanuel. It's quite interesting. Hearing everyone talking, which has been very, very helpful. I know the issue around finance and resources in Zim. I was just going to touch a bit about that. I suppose that the challenges in Zim are deep, and there's a lot that needs to happen in order for us to start actually having systems in place. Because my worry in Zim at the present moment seems as if we are lacking a bit of systems. So it seems as if certain people are doing things they think it's all right. I can give an example. I walked into a chemist and asked for antibiotics without a prescription, and sold antibiotics without a prescription. So there's an issue around, obviously, the system needs to be put in place in order for us to actually go back to a position where we can actually start regulating. So someone needs to be regulating that. What I wanted to talk quickly about is around, obviously, the work we are doing with Brighton, around scaling up training in Zimbabwe. I suppose the challenge we've had, I think, for most nurses in Zimbabwe or healthcare professionals is actually how they can access training. So we have had to, our organization is about actually trying to provide training in Zimbabwe, going to Zimbabwe with colleagues, either medics or other nurses with experience in training, back to Zimbabwe, working with healthcare professionals, for example, nurses and healthcare support workers, to try at least encourage them, to try and keep up, with all the research that's coming up, of which obviously in Zimbabwe there's a lack of research, taking place. There's no research being led by professionals in Zimbabwe, especially around my profession, around mental health, which is another issue, which is another challenge. There's an issue around stigma, especially for mental health people, that people still believe that some people have been bewitched, and so they don't need to take medication, because they've been bewitched. So those are some of the challenges that actually, training and education and health education, like someone mentioned earlier, would support people in Zimbabwe. And because we need to move past that, we need to move past actually the stigma that's attached to people with mental health problems. I suppose most of you know, I've moved in Zimbabwe, I've gone to rural areas, I've seen people with mental health problems, how they are treated. It's a big issue. It's a big issue, something I think we need to work around to try and support people in Zimbabwe.
Thank you, because we wanted to make sure that you also had your perspective. And Dr. Mkono Shuro, what we actually wanted you to comment on is the issue of healthcare training, access to information, as well as integration of pharmaceutical or pharmacist services in your own practice. Can you talk about how it relates to your own practice?
Okay, let me just put it out there. We have been fortunate that we managed to land a medical aid license. We have been trusted with a medical aid license. So we're working on a model that's going to put these ideas together. You see, it has to work as a holistic system. You can't attack the problem at level or in your little corner. The whole system is broken down. So pharmacists are trying to survive. So they'll sell you the antibiotic, even if you don't have a script. They need the money. But guess what? Some of the biggest culprits are your GPs. You go to the doctors, even the specialists, into theaters who don't need to go to theater. Getting your abdomen open, who don't need to have their abdomen open. Because people are desperate and people want to survive. So one of the things we're working on in our medical aid that we'll be launching in the next couple of weeks, we want to bring in the technologies that Malana is talking about. We want to bring in the innovation that Impact Pharmacy is talking about. And I'm looking at the sort of age group that's on this group. The world has changed, and we need to just simply rethink the way that healthcare has been managed. We can't do things the way they were being done 60 years ago when, it was 400,000 white people that were, basically being catered for in the cities. Now you're looking at 8 million people in Harare. Harare is struggling because the facilities that are available and the population you're now dealing with, the disease burden that comes because your soil reticulation system is not working and A, B, C, D. So we need to rethink that whole system, and we bring in technologies, they lower costs. And we bring money and put money in the doctor's pocket. It's pointless to talk ethics to a hungry man. I'll say that again. You cannot talk ethics to a hungry man. He needs to feed his family. It's bottom line. Put money in a man's pocket, then sit down with him and begin to train him. One of the things we're gonna do, and by the way, I work with Dr. Chireka. We've been working together for some time to make this thing a success. Is we want to train doctors, a new prescribing culture. They train us in med school, proper guidelines. How do you treat this? How do you treat this? If we can just follow those guidelines properly, but people are flaunting them so that they can siphon money and do all sorts of funny things. But that will change once we can get money, get the dollars to the doctor's account, get enough dollars to the pharmacist's account, so she doesn't need to. Pharmacists are really fighting against doctors right now. They want to kill each other. That's actually what's happening. But we'll work on that, and I think it's a good thing that we've begun this dialogue. If we can do this more often and actually create a new system, and actually just override the foundation and build something completely new.
Oh, great! Thank you, Dr. Changamire.
Yes, Manu.
Then I'll get to you, Dr. Chireka. Dr. Changamire, you also think about these things from a business case. Do you have any perspective that you can offer for ways we could integrate the healthcare system and financing in Zimbabwe?
Right. Well, a few thoughts. I think the first thing that comes to mind is, just touching on a little bit about, the conversation that we just had on, pharmacists versus doctors. And so I think the one big thing that is just happening right now in Zimbabwe that's causing all of this is most of, and I think it might have been Dr. Mkono who talked about it, is most of what's happening right now is fee for service. So you do something and then you get paid. And it's been, like a really big issue, especially in other bigger systems as well. Because what that does is it incentivizes people to do more and more and more and more, which is not what what you want your physicians or your pharmacists or your healthcare providers to do. And what has been done in other systems from what people call a fee-for-service model to what you call a value-based model. And it's almost similar to, I guess, maybe what some organizations like CIMAS is doing. It's a capitated model. You pay a certain amount for somebody to be taken care of. So if you give a physician, say, I don't know, I'm just going to throw out numbers here because I don't know what the numbers are in Zimbabwe. But say if you gave your physician $500 per patient, say, well, you do whatever you can, but I'm going to measure you on the quality of care that you're providing. If you can provide good access and good quality, and you save dollars, whatever you save is going to be in your pocket. Then that incentivizes physicians and healthcare systems to actually do what is right to improve the outcome of that patient and to so from a financing standpoint, I think there's got to be a change in the way we reimburse doctors and hospitals and pharmacists. And if we can do that from, and for most folks or most countries, it actually happens at the financing level. The payers, the insurance companies are the ones that decide. But I know Dr. Chireka is practicing in the UK. The NHS actually is the biggest payer in the UK, and then they decide at a policy level what needs to be done from a financing standpoint. It's some of the challenges that we are facing here in the US as well, that it's traditionally a fee-for-service model. Doctors were just being incentivized to do more, get a CAT scan, do procedures that are not necessary, so paid. But now the government, which has been the biggest payer, is putting in, regulations and policies that are going to change how doctors are going to get paid. And that has slowly begun to change the way people are practicing. And now we're actually even incorporating more of what we call advanced providers, our nurses, our social workers, our pharmacists. How do we work all together to improve the quality of care for our patients and save dollars for the system? At the end of the day, I think there's going to be an integration of pretty much everything. If you think of your healthcare services, your diagnostics, your financing, and your allied health professionals, that will help really put everything together in a sustainable way. And going with what Marlon has been saying, technology also helps improve some of those cost efficiencies that we are struggling really hard to to improve within the healthcare system.
Great, thank you. I know Dr. Chireka, you had a comment.
Yeah, I totally agree with what Dr. Mkono Shuro said, that you cannot talk ethics to a hungry doctor. And also what Chris says, rightly identified, that there are no systems. So it's what we call survival of the fittest. Each and every person is in survival mode. So that is where the problem that we are having. You see a doctor, you see a nurse, you see a pharmacist, they are in an operational mode. But we need to move away from that. We need to start having systems and have a system leadership. And also we need to have what we call compassionate leadership. When I hear Dr. Mkono Shuro talking, these are the leaders that we want, people who are compassionate, people who are caring for the patients. So this is what we need. We need a cultural change, a cultural shift in everyone in Zimbabwe, so that people now put patients at the heart of their decision making to make sure that we get things done better. The other thing that I'm also seeing is that a patient does not think about the resources. If they are on a medical aid, they would want to abuse that medical aid until the medical aid run out of money. A doctor or a pharmacist, they are also not thinking about the resources. They want to drain that medical aid and also run out of the resources. But what we now need is we want leaders who have got a strategic thinking, who think about the whole system. That's why I'm keen to be involved, and I've been involved with Dr. Mkono Oshuro in this Ultramed Medical Aid Society that we will be launching. It's going to shake the whole system. But what we are not thinking about a GP at Magaba, we are thinking of having a whole system change, strategic thinking. We should know that whatever you do in your practice will have impact on the whole nation. Whatever you do in Magaba will have an impact on the whole nation. So these are the things that we just need to educate ourselves, remind ourselves. The resources in Zimbabwe are there. But if you look at what is happening with medical aid, 50%, 70% is going to administration. Instead of that, only 9%. If you look at the government, where are the resources? Budget for health, it's number 4, number 5. We are using resources somewhere. So to me, if we now have got compassionate leadership that thinks to make you put the health of the nation at the forefront of everything, the resources that we have, using people like Dr. Malone to make sure that we use technology to cut costs, technology to reduce wastage, and working as a team, we can do something. To me, I'm up for that challenge, and to prove to people that you can have accessible health in Zimbabwe, affordable health in Zimbabwe, not what we are having at the moment.
And I mean, Emmanuel, just to add on as well, I suppose we need to learn from other countries as well. You know, in Uganda, they were struggling, you know, most of the times. But if you look at the healthcare in Uganda now, with the input from the diaspora, their healthcare is changing. It's absolutely changing. So we need to move, like, I mean, Brighton is saying, what's driving the change? What's driving, you know, healthcare in Zimbabwe? If it's business driven, and I don't even qualms if, you know, people wants to make business and stuff like that, that's fine. You know, it's the way we live in. But if it becomes a business driven society in terms of healthcare in Zimbabwe, then we'll struggle. We'll struggle because we'll stop thinking about patient needs. We'll stop thinking about what we can do for the patient. So I suppose, I mean, from my point of view, I think we have started this discussion. We need to start thinking about solutions. How best can we support Zimbabwean healthcare? Because we can talk about the problems, guys, and the problems are there. And I see them every time I go to Zimbabwe, the problems are there. But what we need to start doing is we need to start offering ourselves, what can we do in order to have a positive impact in Zimbabwe? The last time I was in Zimbabwe 3 weeks ago, I spent about 45 minutes with the Minister of Health and Childcare, Dr. Pararenyato. You know, we had a very, very positive discussion. And what I was saying to him was, you know what, people from the diaspora, some people in Zimbabwe, we want to get involved. We want to support Zimbabwe. We want to help healthcare in Zimbabwe. And I think that's what we should be saying. That should be our message. We want to get involved. We want to be part and parcel of the solution. We've identified the problems, but the problems have always been there. The needs have always been there. But now we need solutions in order to help Zimbabweans.
And I think we've already started to kind of go, because just from listening to the discussion, I think it's at least from like what I'm picking up, it seems like the biggest competition, the biggest problem we have is this whole fee for service thing. And I think my challenge would be, I don't remember who it was that said that they're starting a medical aid. I think we really do need to start looking at going into an outcomes-based service, so that, you know, there is that, when you look at your payment model, you look at the physicians and say, okay, they came in, you ended up opening up their abdomen, they got this, are they better off or are they worse off? And then you track some of those outcomes for every claim that you make. And if it seems like the patients end up with worse outcomes, then they don't get paid or they get cut off. Same thing with the pharmacies, do the same thing. So if you're noticing that there's this growing trend of certain places going and like prescribing certain like giving medications if they're not supposed to, and if the outcomes are worse, so because these patients follow up with the physicians, right? So if they come in later and they say, hey, I got this medication from this particular pharmacy, then add it to some of this databases, so that way, you know, hey, they are not an outcomes-based pharmacy, so let's get them off the medical aid list. Because I think for as long as we keep it as a fee for service, there is going to be that competition, then the ethics is going to be an issue. But I think that's going to be like my one challenge for you. You're already starting a medical aid, and I think maybe start looking at how to create an outcomes-based society as the incentive.
Thank you.
Yeah, you're hired. Definitely hired.
So I guess we're only left with a few more minutes, and I just wanted to make sure that I answer some of the questions from the audience. One of the other questions that we had was, we usually hear of Zimbabweans traveling outside of Zimbabwe, like to South Africa, India, to access healthcare services. What are some of the, it seems as if one of the things that we've noticed is the quality of care leaves a lot to be desired. What are some of the ways that we can make sure that going forward we make Zimbabwe one of the best healthcare systems in the country? So to answer this question, we are just going to do some closing remarks, and we'll go in the order. We'll start with you, Dr. Mkonoshiro, then Dr. Changamire, Dr. Kaseke, Dr. Nyakabao, Mr. Dzikiti, and then Dr. Chireka. Dr. Mkonoshiro.
Yes, as a closing remark, well, what I can say is we have lots of potential. We've got the infrastructure already. It's just a question of software. It's a question of we need an operating system that works. Zimbabwe, they've tried. They've done a pretty decent job over the years, and we give it to them. It's now our responsibility as this generation, and just change a little bit what needs to be changed. The culture, the way things are done. Use the resources that are there. Like Dr. Chireka always says, reduce wastage. There's too much wastage in Africa. We've got the resources, we just don't know how to budget them nicely. We'll do that. And bring in all these innovative ideas, pharmacy, from the technological people, and create a system, one system that works, and that cannot be corrupted by a single individual. A foolproof system that is beyond any capacity for any human being, whether the CEO or the board directors, to corrupt. So proper corporate governance. That's what we're bringing together.
Great, thank you. Dr. Changamire.
Yeah, no, I agree with what Sydney is saying. That I think the two things that are key and that are important would be, one is innovation and entrepreneurship, and the second one would be regulation and policy. From an innovation and entrepreneurship standpoint, I actually truly admire and I'm inspired by what everyone is doing, from all the work that Sydney, Nash, and Marlon, and Brighton and Chris. The more we have folks who are trying to innovate and try to come up with solutions that would work to improve, solve some of the challenges that we have, I think the better we'll get at it. Having that mindset of continual improvement. Of course, there are some things that are going to work, and there are some things that won't work as well. But as we're completely assessing what we're doing and iterating in the process, I think we'll get there. The next thing would be, more from a regulatory standpoint. Healthcare, in and of itself, if it's not regulated properly, there are, these risks that we can put patients and the public in danger because there are some folks who end up doing things that are not really proper. So making sure that all the different healthcare professionals are regulated and they are operating what I'd call at the top of their license, and they're not going beyond what they were trained to do. I think as well. Okay. And lastly, I want to say thank you to you for getting the forum together. I think more of these conversations really pushes the agenda forward, and just kudos to you for all the work that you're doing as well. Thanks for making me be here as well.
Thank you, Tej. Dr. Kaseke.
I think my biggest takeaway, I guess coming into this, I didn't realize that there's so much greater need to work as a team. Because like from what I'm used to and from like the experience that I've gotten, like I've always looked at the healthcare system as one team, but it looks like there's so much more division that I wasn't even aware that it is that far back, that, you know, instead of looking at, hey, like the patient comes first, right? So we've been talking about, hey, the patient is what comes first, and we want what's best for the patient at the end of the day. And it's, I think the biggest takeaway, just going back into the field and going back into the pharmacists that work for us, the ones that come and do locums for us, is just that reminder of we are one team, you know. And I think it's sad when we get to a point where it seems like, you know, nurses are competing with the doctors, with the pharmacists, when ultimately if we all come together, then the patient is going to be better off. So my biggest takeaway, I guess, and some of what I'm going to be thinking of is how do we get like the profession as a whole, and how do we get like the different professions to come together more, instead of maybe sometimes instead of just having, you know, meetings where you just have physicians or you just have pharmacists, bring everybody in one room. Let's talk about some of these issues and try to figure out back to being a team and not being, you know, this person versus, or this profession versus that profession, you know.
Great. Thank you so much. Dr. Nyakabao.
Yeah, where we are is not really a happy place. This is a dark moment in our history. But I think to bring the light, I'll just summarize it. I think what's really required is one thing: it's courage. Courage to do the right thing. You know, Zimbabweans are kind of like well known for being educated people. You look in our government, you see doctors, professors, and so forth. But I think what's lacking is the courage to do the right thing. That we know what we should be doing, but whether it's fear of being poor or fear of premature death, I don't know what it is, but some certain fear is then leading us to then compromise. Courage to then say, if I know I should only be sticking to over-the-counter drugs, then let me stick to that. If I know that, no, this patient does not need for me to, you know, order this kind of scan or test or so forth, then stick to that. Courage on your part, as far as guys in the diaspora, to say, if you really want to come back to Zim, then no one is going to bring you, you have to bring yourself. And when you arrive here, you gotta be courageous to be able to fight for the system that you want to put in place. Because the problem with Zim is we really have weak institutions. And we can't expect the health sector to be the one that's booming when the agricultural sector, the mining sector, and all the other sectors are not working. We are all living in this interdependent kind of system. So it's going to require courage. If you come back home, lace up your whatever boots and bring your brass knuckles and be ready to fight for what you believe should be done.
Great.
Thank you very much, thing up.
All right, Mr. Zikiti.
Yes, I mean, I've got just 2 points I just want to emphasize. I think that the first part is, everyone in Zimbabwe, everyone in the diaspora, or majority of people want to see a positive change in Zimbabwe. Like I was saying, spending time with the minister, I can see he wants to see positive change in Zimbabwe as well. And I believe most of the guys on the panel this evening here in the UK, it's in the evening. Everyone wants to see positive change. The fact we are discussing is because we want to see positive change in Zimbabwe. And I think how best we can help, I suppose, is, I was involved in writing the mental health strategy in Zimbabwe recently. And we spend a lot of hours looking at it, supporting it and making sure that actually it's being done, it's being written. Yes, obviously we've got challenges in trying to implement it, but in the first instance, we've got a strategy which can work in Zimbabwe. And I suppose with everything I've heard, I'm not a medic in terms of I'm not a pharmacist or a doctor, but what I've heard today, it seems as if, we need to have some standards and guidance or national policies in Zimbabwe to support everything we are doing in Zimbabwe. And I suspect most of the people on this panel can be involved in writing those guidance or in writing the standards. So if we've got issues around how medication is being prescribed, maybe reviewing the standards we've got and rewriting those standards and having guidances for doctors, like what Dr. Mkonoshiro was talking about, so that we can start supporting people to do the right thing. And I honestly believe, we can do it in Zimbabwe. I'm quite positive that, we've got so many people who wants to see that positive change. So let's do it, guys. Let's stick together. Let's support each other and make sure we are doing it. And I can see Zimbabwe changing and getting back to where it was before. So thank you for inviting me, Emmanuel. This has been great. I've learned a lot from everyone else, and hopefully we'll catch up very soon.
Okay, great. And then Dr. Chireka.
Thank you very much, Dr. Magara, for this platform. And Dr. Changamire, Dr. Kaseke, Dr. Nyakabao, Mr. Dzikiti, it has been a good discussion. In conclusion, I want to say that moving forward, we must stop working in silos. Them and us should stop that issue of saying nurses, pharmacists, doctors, or funders or providers. I think we are here to work for the patient. Patients must be at the heart of decision making, and we now need a new culture. The new culture starts with us. If we can be able to work together, I like the way we work with Chris, because he's not a doctor, but he's actually a respectable person, because what he contributes on the table, it makes us be able to put things in place. So this is what we should be doing now, to make sure that we put people in their right place and make sure that they help us to take this forward. I've got a few more things to just say. The other thing that we need to do in Zimbabwe, let us respect the US dollar and give its proper value. I think there's a problem. We're coming from hyperinflation, and our costs, or the way we are costing things in Zimbabwe, it's a bit out of this world. So we need to actually make sure that we have looked at that as well. And the other thing that I also want us to look at is just say structures are there, the professionals are there. Let's join hands together. There's no need to go to India because we've got better facilities in Zimbabwe, but only cost is causing us a problem. Thank you.
Okay, great. So in conclusion, I think we are now, it's now 3:10 here. I really want to thank all of you guys. I know we've been going back and forth through emails and trying to make sure that this happens, and I'm really appreciative that all of you could be able to make it. And I just want to thank also our viewers who have been joining us online, and say, feel free to just reach out to me, and we can be able to continue the conversation. I know my email address, I'll be able to share it if you just reach out to me through the circles. All right. Thank you, guys. I'm just going to, this is where our broadcast ends.
Thank you.
Thank you, Dr.